Audible, ma'am.
Today we have with us Dr. S. Vijayalakshmi, Principal, Vignesh Nursing College, Tirunnamalai, speaking on the topic antenatal care. Dr. Vijayalakshmi is a transformational and dynamic leader with 24 years of service and proven expertise in clinical, teaching, research, administration, and program development. She is a PhD guide in 3 universities and was elected twice as a governing council member in this university. She was actively involved in policy revision and decision making during her tenure. She actively participated as a Senate member for 12 years and Faculty of Nursing for 3 years in this university. She was appointed as a government nominee for Executive Council member in Tamil Nadu Nurses and Midwives Council for 6 years. And she was elected as a Trained Nurses Association of India Vice President between the years 2011 and 2016 for Tamil Nadu branch. During her tenure, government job for students graduated from self-financing institutions were obtained. She is now the Secretary of TNAI, Tamil Nadu branch. She has presented 110 concepts, scientific papers in state, national, international conferences within a period of last 15 years. She has organized 2 Government of India sponsored training programs in management and obstetrics skill training. She is editorial advisory board member for many nursing journals and has published books, articles in national and international journals. To add on, she has won many awards, among which she was awarded with silver medal for best outgoing student in BSc nursing during her training program. And in the year July 2011, she was honored with Best Nursing Educator Award by Education Today magazine. And May 2012 was honored with Best Teachers Award by this university. We also have along with us 2 panel members, Professor Dr. J. Sudha, Principal, PSG College of Nursing, who is also currently the GC member of this university, and Professor Amuda, HOD, Omayal Archie College of Nursing. Madam, now can we start, madam?
Yes, ma'am. Hope I'm audible to everyone.
Yes, ma'am.
Yeah, thank you, ma'am. Thank you. I take a special privilege to welcome one and all for this presentation, which has been organized by the Tamil Nadu Dr. M.G.R. Medical University. Under the able leadership of Dr. Sudha Seshayan ma'am, Vice Chancellor of the University, with her 4 team members, Dr. Shivashankita madam, as well as Dr. Pushkala ma'am and other team members. Thank you, ma'am. Thank you for this opportunity which has been given by the university to all the colleges under one umbrella to have an efficient imparting of quality nursing education to all of us. Thank you, ma'am. Thank you for this wonderful opportunity. I think a way long from the university journey, this is the first time we have a webinar only exclusive for this nursing profession. Thank you so much, ma'am. So coming to the presentation, as already discussed, I'm Vijayalakshmi, Principal of Vignesh Nursing College. Today, going to present the topic on antenatal care. Yeah. So as a part of introduction, as we know, antenatal care plays a very, very important as well as the vital role for every one of the mother who has been pregnant. And it is a very precious period in the woman's age group. And we all know age old, there were 8 or 10 deliveries, even if 1 or 2 child has been dying during the time of pregnancy or the time of delivery, it is becoming like yeah, it is a loss for every pregnancy. But nowadays the trend is the couples having either 1 or 2 children. So each pregnancy is going to be a very, very precious one. And also the antenatal care is going to play a very biggest and wider important role in bringing the safe pregnancy period as well as the care which has been given during the time of antenatal period is going to have a greater impact during the intranatal period as well as in the postnatal period. So with this, we'll just go with the statistics. If you see, every year there is 213 million of Just 1 minute. Yeah, every year there is 230 million of pregnancy in the world. So if you say in India, it accounts for the maximum number of maternal deaths in the world. And if you see another statistics, 17% of the women died of complication due to pregnancy as well as childbearing. In that statistics, if you see 10,000 of 2.89 lakh women has been died in the year 2019. So we really missed in achieving the Millennium Development Goal for reducing the maternity mortality rate to 109 per 1 lakh population by 2015, because at that time the MMR is quite high. It is really 130 per 1 lakh live births. But the latest figure has been 103 per 1 lakh live births in the year 2017 to 19. So it is an indication that we have missed in the year 2015, but we are gradually improving in reducing the maternal mortality rate, which indicates the antenatal care as well as the intra-postnatal care has given much importance in India in the recent years. Coming to the goals of antenatal care, the first aim of the antenatal care is to reduce the maternal as well as the perinatal mortality and as well as morbidity rates. Because if a proper care is given during the time of antenatal period, especially identifying the high-risk pregnancies and accordingly giving the treatment, and mostly preventive aspects has been adopted during that particular period, it helps in a larger number of reduction of the mortality as well as the morbidity rates. And second important factor is to improve the physical and mental health of the woman as well as the children, and to prepare the woman for labor, lactation, as well as the care of her infant. And also the fourth thing which goes in hand with the first goal, like detecting and early as well as treating properly the complicated condition that could endanger the life or impact the health of the mother or the fetus. So the early identification and prompt treatment is also an important goal of the antenatal care. Just I can't move the next page, ma'am.
Ma'am, we are not able to hear you.
We can't move the next page, ma'am. Is it audible?
Okay. 1 minute, ma'am. Amma, அடுத்த slide move பண்ண முடியலன்னு சொல்றாங்க. Okay, ma'am, you only have shared the PowerPoint, no, madam?
Yeah, yes, ma'am. That has come as a disabled option, ma'am. That cannot be.
1 minute, ma'am. Let me check. நம்ம ஏதோ disable பண்ணிருக்கோங்கிற மாதிரி சொல்றாங்க.
The number you have dialed is current.
Next slide போக முடியல பாருங்க.
Ma'am, we have not done anything. Ma'am, previous slide போக முடியுதா பாருங்க.
அதுவும் போக முடியல மேம்.
அதுவும் போக முடியல. நம்ம எதுவுமே பண்ணலையே. So far we have not done anything. We have not gone near to that system at all.
Yeah, ma'am.
இந்த பண்ணு.
Just 1 minute, ma'am.
Yeah.
Because from our side, we have not done anything, ma'am.
Yes, ma'am. But that option has been disabled, so we can't move either previous or the.
Okay.
Can I share from the first, ma'am? Can I stop sharing and again?
Yes. நீங்க அதை stop பண்ணிட்டு share it again, ma'am, so that we can bring it to this slide. Sorry.
Cancel பண்ணிடுறேன்.
Fine.
Cancel பண்ணிடுறேன்.
Okay.
ஒருத்தர் போய் ராஜலட்சுமி அடுத்ததா கூப்பிட்டு வரீங்களா?
பண்ணு. Sharing first stop பண்ணி பாருங்க. மீட்டிங் விட்டு வெளில வந்துருப்பாங்க. ஹலோ மேம். மேம் சொல்லுங்க மேம். Sorry for the inconvenience which has been created. Yeah, coming to the definition of the antenatal care, as we have already said, antenatal plays a very important role. But coming to the broader definition of the antenatal care, it starts from the conception of the conception and it just ends with the beginning of the labor. But to say the fact, it is not actually, the antenatal care actually doesn't start from the time of conception. It starts from the birth of the female baby, because all of a sudden the nutritional part as well as the mother's health cannot be improved all of a sudden within the 9 months period of time, where she has to care the extra nutritional requirement by the fetus has to be met. So antenatal, it is the care which has been referred not only from the time of conception to the say the fact, it has to be started from the birth of the female baby. All the ways, like by the nutritional, by the exercise and by the psychology and preparing her for the parenthood during the time of menstruation, adolescent, everywhere she has to be prepared in a motto of bringing her to a normal healthy condition, physically, mentally, socially, spiritually, and she has to deliver a baby in a healthy condition. So then coming to the components of antenatal care, we are actually, the components of antenatal care is a very a larger topic, but today we are going to discuss on the grounds of history, physical examination, laboratory data, antenatal visits and antenatal advices, just confining ourselves to the normal pregnancies. This will be done. So coming to the history of Sumar disabled. Coming to the history of antenatal care, so as we all know, the history is being taken from the mother on different grounds, like physical history, like socio-economical history, personal history, as well as obstetrical history, in which includes present medical history, past medical history, and these are the areas where we have to collect. Coming to the specifically, when we talk about the personal history of the mother. Just 1 minute. Yeah, coming to the personal and social history, when we talk about the woman's age plays a very role because elderly primary will have an impact, whereas the too young mother also has a different impact during the time of antenatal period. Occupational hazard also can be correlated, and also we also take the some messages like address, phone number, marital status, married or widow or separated, whichever it is, and the duration of the marriage, which also gives us some information regarding the fertility of the woman. Might be the age duration of the marriage after 10 years, first time she's getting conceived, or just soon after the marriage she's getting conceived, and also the religion as well as the nationality, language. These are the basic information which we collect. So coming here again, coming to this personal as well as the social history, these are the informations, though it is very small in nature, it gives us a wide information regarding how the pregnancy will be taken care. Next, we also is going to discuss regarding the obstetrical history. Stop and look up. So like coming to this menstrual history, which is again very important type of information which has to be collected, like her last menstrual period. Last menstrual period, whether it helps in knowing the time the conception has been started, the age of menarche, and also like the regularity and the frequency of the menstrual cycle. Regularity and frequency of the menstrual cycle also has some mismatching with that of the EDD when we are calculating when her periods are very much irregular. And contraception has been used by the mother. For example, I said the duration of the marriage. If she is 7 years after the marriage, like the first time she is getting conceived, that is the matter. We cannot say her fertility nature is very poor if at all she is using the contraception method. So that particular part also has to be collected, and any previous treatment of the menstruation irregularities, whether it has been, because many of the antenatal persons or many persons before her pregnancies, they have the difficulty of having different menstrual problems, especially PCODs, polycystic ovaries. So this all the information has to be collected. But coming to our antenatal period, the LMP should be taken as a note as a last menstrual period, and for calculating the EDD, everyone should go 9 months plus 7 days. Otherwise, we have to go back 3 months and add up the 7 days. So these are the things which has to be collected under the heading of the menstrual history. மேம் நான் அடிக்கடி அது ஆஃப் ஆகுது மேம், திருப்பி ஃபர்ஸ்ட் இருந்து போறோம். நான் வந்து உங்களுக்கு ஸ்கிரீன் ஷேர் பண்ணி விட்டுருவா. மெயில் ஐடி ஏதாவது சொல்லுங்களேன் மேம். ஓகே ஓகே. பண்ணியா மெயில் அனுப்பிடலாம் மேம்க்கு. Very sorry for the inconvenience. Like next, we are just after finishing the menstrual history, we also go with some of the current problems with the pregnancy, which has been taken a note of it. We should also ask the history of a person having nausea, vomiting, abdominal pain, headache, urinary complaints, vaginal bleeding, edema, backache, heartburn, constipations, because to certain extent, these are the problems which has been expected during the time of pregnancies. Like a nausea, vomiting, if it usually happens in the first trimester as the mother is having like hormonal changes, especially when there is increase in human chorionic gonadotropin hormone, all that, the nausea, vomiting will be there. Abdominal pain, sometimes it is confused with the gastric pain also, which has some inconvenience. But whenever these are the problems can be asked, but when it is in the normal limit, it can be accepted as a normal. But for example, if there is a profuse vomiting, she may go into the state of hyperemesis gravidarum. Abdominal pain, when it is really due to the uterine contraction, she may go in for abortion. So like that, these are some of the issues which has to be asked by a nursing personnel. And also coming to the edema, which is may common when the mother is having like independent edema, when she's putting the leg down for a longer time, it may happen, but it has to subside on its own when she sleeps in the rest, or she lifts the lower extremities. If it is there, along with that proteinuria is there, and along with her blood pressure is high, it can be just compared with that of the PAH. So each of the information has to be correlated along with the knowledge, along with the differential thing diagnosis, which we can make it out and refer to the obstetricians as per the information noted. Coming to the obstetrical history, it is the imperative duty of every healthcare personnel, especially the nurses, to know what is the gravida, what is the para, what is the abortion numbers the mother had, and how many living children, whether they are healthy, whether they have any genetic deformities, whether they are after a period of time, whether the children were dead or it is because of pregnancy related complication. These are the information has to be known, and weight of the infant at birth in the previous pregnancies and the length of the gestation. Why? If it is going to be a bigger baby or preterm baby, or it is because of prematurity. So these are the information can we give the clues in the succeeding pregnancies, and also the length of the gestations, especially if it is a preterm labor or postnatal delivery. And also we should think about the labor experience, the type of delivery, location of birth, and type of anesthesia used during the time of previous pregnancies, as well as the maternal and infant complications. Each has a very different experience. For example, a labor experience, whether she has prolonged labor period or a prolonged pregnancy period, or the prolonged pregnancy period may have any contracted pelvis, case a history, type of delivery, whether it is a forceps delivery or venous extraction, or it is cesarean section. If it is going to be cesarean section and it has happened just a few years before, then we can say this time also she has to go for the elective LSA. So these are the determining factors which helps and gives a guidelines for the future decision making. And coming to the medical surgical history, so these are the coincidence informations which has to be kept in mind when we discuss with the antenatal care, whether mother has an diabetes mellitus, whether mother had an hypertension, or it is pre-existing, or during the time of pregnancy it has occurred, whether it is gestational or just before the pregnancy it has come in. So these are the information has to be noted. And also we know whether the previous operation is because of cesarean section or any genital repair has been done, any cervical circulatory operation has been done, or any other abdominal surgeries like appendicitis or any gastroenterological surgeries which has been happened, because for everything that scar mark is there, and the scar expansions will be there when the abdomen is growing for the pregnancy woman. So that has to be noted during the medical surgical history, which has to be kept in mind. And coming to the family history, so we should also have the family history of diabetes mellitus or hypertension or heart disease complicating cancer, anemia, which is a quite common history which all the nursing students will take in order to see whether any genetic history is going to be the preceding factors for getting complicated with this present pregnancy. Okay, so the second major, after finishing with the detailed history collections, all these clues gives us a wide information how we are going to deal with the antenatal mother. Then coming into the personal touch with the physical examination, the head to foot examination has to be done on the mother in order to detect any undiagnosed physical problems that we have missed out during the time of history collections. So this gives us a base Can everyone hear me?
Now only you are audible, ma'am.
Yeah, now it is audible.
Now it is audible.
Yeah, thank you, ma'am. Thank you, ma'am. So coming to the physical examination, we have two types of physical examination. One is the general physical examination, which includes head to foot assessment, and second is the obstetrical examination, which includes breast, abdomen, as well as the perineum. So coming to the first physical examination. So coming to the head to foot in assessment. So we generally see the body build, whether the mother is obese or whether she's thin, whether it is an average. So thin, we know she's underweight, or sometimes it is less, for example, 45 kg and less. There is a risk of mother having some nutritional deficit, as well as she may also go in for preterm labor or anemia, HB, all things has to be taken out. When the mother is obese, whether her flabby abdomen and the obesity itself will be a contributing factor for sometimes if she's highly nutritious, because of that it give rise to a big baby, the weight of the baby can be more. So these are some general information which is not so much of evidence based, but it just give you some clarity on that particular factor. And nutritional factor on overall, whether she's good or average or poor in according to the height and weight. And height, it has a direct relationship to that of the pregnancy, whether short stature mother, if it is short
Ma'am, you are not audible now, ma'am. No, ma'am, you are not audible.
Is it audible now?
Yes, ma'am. Yes, ma'am. Now.
When it switch off, sometimes it option. Okay, so so we have discussed about the short stature also, like 145 centimeter and below the height is going to be, the pelvis is going to be small, and again it has an impact during the time of delivery. And weight also, it has an impact that weight should be checked for the mother every time when she comes to the visit, because we expect 8 to 10 kg or 10 to 12 kg of weight gain during the time of pregnancy. And coming to the weight, like first time when she comes to the antenatal clinic, her weight should be checked, and periodically throughout the pregnancy the weight has to be monitored, and so that we can say whether her weight gain is proper. And if the weight gain is proper, we can expect the normal term baby minimum 2.5 to 3 kg of the baby weight, or it gives some other information that we have to take into consideration. Coming to the pallor, like jaundice, and coming to the tongue, teeth, gums, tonsils, which all has to be have a check-in. And we expect the gums, because of the sponge and progesterone hormones and relaxin hormones, the gum bleeding is expected. And coming to the neck, we also to go for the neck vein distension, anything is there, thyroid gland enlargement is there, because most of the time the thyroid gland complicating pregnancies also play an important role. And coming to the edema, this is on assessment. We have already discussed about the lower extremities edema, which may have an impact leading the mother to go for the PAH. And coming to the systemic, like integumentary system, we can also observe for rashes, moles, pruritus, bruises, pigmentations, tumor. Like in integumentary systems, so normal changes in the pregnancies, like the cholasma, which is a butterfly-like rashes which happens in the face, that can be accepted. The linea nigra, stria gravidarum, which are the normal expected skin changes, can be accepted. But other than that, few mothers also face like pruritus, itching. So in that case, we as a nursing person will say that we have to cut short her nails, and also we said that each scratch cycle will be more. So in that, how to use some soothing things or some lotions in order to reduce the pruritus. Hair and scalp. So scalp infection, lice, dandruff, that also has been checked in. And head, the dizziness, fainting, sinusitis, involuntary movements should have a view into that. And eyes, given very clarity, like if the mother is having any blurring of vision or some blind spot in the vision, diplopia, photophobia, sometimes hypermetropia, hypopia. So these are the conditions which have to have a checked, and hearing acuity also should be checked with that, and some ear discharges, tinnitus, vertigo, ear infections, if anything is there, should be noted. And for the nose, mouth, throat, so something like epistaxis, discharge, because some of the hormonal issues like have a direct impact on the mucous. Are you able to hear me?
Yes, ma'am. Now we are able to hear.
So cardiorespiratory systems, genitourinary systems, and as well as the musculoskeletal vascular system has to be noted, where the breathing pattern, whether the mother has a regular breathing pattern, respiratory rate is within the normal, like 16 to 24 breaths per minute. And coming to the CNS, slurred speech, memory, vertigo, convulsion, this all has to take a look into. And coming the very important part like vital signs, the blood pressure, pulse, temperature should take a note. But usually we think if the mother has 120 by 80 mm of Hg, it is normal, or 130 by 80 mm of 130 by 86, 84, it is normal. But the best way to identify the blood pressure is the baseline values of the mother has to be noted. For example, if mother already before pregnancy, if her BP baseline is going to be is only 100 by 70, during the time of pregnancy, if she has 130 by 86, 88, some values like that, she is considered that her blood pressure is increased. Systolic pressure, if it is more than 30 mm of Hg in the baseline value, that, and diastolic pressure is 15 mm of Hg is more than the baseline value, it indicates a sign for PAH or toxemia. So it has to be noted. And the pulse rate, as we know, it is ranges between 60 to 90 beats per minute. And respiration 16 to 24 beats per minute, and also temperature 98.4 or 6 degree Fahrenheit. So with this, we are finishing with the physical examinations, general as well as the systemic. Coming to the abdominal examination. During the pregnancy, the inspection, palpation, percussion and auscultation of the abdomen becomes mandate. So just with the abdomen alone, we have to inspect on the abdomen for the skin changes where we have already previously stated, like linea nigra, stria gravidarum, or any scar marks of the previous operation done. And the size of the abdomen also, it should be inspected for the height of the fundus, which determines the period of gestation. For example, at the level of umbilicus, it should be 24 weeks, and above the level 4 fingers above, it should be 28, 32 weeks. Why it has to be done? In case if it is not appropriate to the gestational age, it can be less than the period of gestation, we can consider it as a low birth weight baby, or if it is more than the period of gestation, we can also come to the conclusion it is the large baby. So these are the information clues we are getting. And also sometimes if there is a large baby and if it is associated with multiple pregnancy, twin pregnancies or polyhydramnios, this also gives the information the abdomen size is enlarged more than the normal. And sometimes big baby also give us the information that it has been enlarged. So we have said the size of the abdomen has to be noted for. For example, there is some factors like some evidence-based research has been identified that 30 weeks of pregnancy, the height of the fundus should be 75 centimeter. And thereafter, for every week, 1 inch should be increased. That is 2.5 centimeter has to be increased. So by 40 week, the mother pubic fundal height should be 100 centimeter. So this is by centimeter, we are seeing the size of the fetus. And by the weeks, we know, as we already know, at the level of symphysis pubis, it should be 12 weeks. At the level of umbilicus, it should be 24 weeks. And at the level of zivis sternum, we say it is 36 weeks. And above the symphysis pubis, it is 16 weeks. Below the umbilicus, it is 20 weeks. And 4 fingers above the umbilicus, it is 28 weeks. And 4 fingers below zivis sternum, it is 32 weeks. So in this way, the size of the uterus can be compared with that of the normal gestational period, whether it is low or higher than the normal. And coming to the shape of the abdomen, so usually if the abdomen is longer in the longitudinal direction, we say the lie is longitudinal. If it is horizontally, we can say the lie is not longitudinal lie. The baby is in the transverse position. So that can be identified. The abdomen should be abdomen is lower and broad if it is in the case of the transverse lie. So this is another information. And fetal movement also inspected on during the time of inspection itself. We can see the movements in the abdomen. If you can't wait for a longer period, we can also ask the mother whether you can feel the fetal movements. Coming to the contour of the abdominal wall, we also should also check whether it is a pendulous abdomen, whether the lightening has occurred, whether the protrusion of the umbilicus is there, full bladder, because the flat umbilicus will indicate the baby mother is at the term. And fetal heartbeat can be heard by stethoscope just after 20th week. By Doppler, we can hear by 8th week. And the normal fetal heart rate is 120 to 160 beats per minute. So coming to the palpation, when you finish with the inspection, second thing is the palpation. So the palpation which clearly indicates which week of gestation the mother is, whether she is more than the period of gestation or lesser than the period of gestation. So when we see the uterus may be higher than expected. So what all the things, if for example, we are expecting as per the gestational age, the height of the fundus should be at 24 weeks. Whereas when we palpate, the height of the fundus is at the 28 weeks or 32 weeks. What all can come in your mind? The baby may be big, or the mother will have multiple pregnancy, or due to polyhydramnios, it is big, or mistaken date of the last menstrual period. Might be should have been earlier LMP, but should have said a long LMP dates. Sometimes it is very simple also. That the uterus may be lower than the expected, like when she expects that abdomen height should be at the level of 24 weeks, whereas the abdomen is at the level of only 20 weeks. So we can come to some conclusions. Is an imaginary conclusion. We cannot confine unless we prove with that of USG. It can be small fetus or M.G.R will be there, oligohydramnios, mistaken date of the last menstrual period. So these are the probable things which can come into our mind. So coming to the palpation, the picture A says about the fundal palpation. So in the fundal palpation, when we palpate, first thing we should know whether the fundus is empty or you can feel any pole, whether it is a podalic pole or any cephalic pole. So when you palpate, if it is empty, either in the fundus as well as in the pelvis, it is empty, means we can expect it is a transverse lie. But if you find something, a bigger mass is found in the fundus, we have to palpate whether it is a soft or whether it is hard. A soft podalic pole, if it is there, means it indicates the presentation is a cephalic presentation, whereas a hard mass is there in the well-defined hard mass. If it is felt in the abdomen, especially in the fundal region, it indicates the breech presentation. So this is the information we get through the fundal palpation. Coming to the lateral palpation, we have two types. One is right lateral palpation and another is the left lateral palpation. So when a mother is just lying down, the hand where we kept according to the right and left of the mother, it has to be decided, because we may stand in the one direction. So determining our right and left, it should not be considered. It always should think about the right and left of the mother. So on right lateral palpation, if you feel a regular continuous mass, and in the left lateral palpation, if you feel some podalic pole or irregular pole, so not podalic pole, irregular mass has been found, like some fingers, nodules, it is not continuous. You know, and the back will be continuous. Along with the back, we can feel the occiput. Along with this irregular mass, we can feel the sinciput. So that we can identify in the lateral palpation. And third is the fourth, D is the pelvic grip 1. So pelvic grip 1, what we have to say, whether the sinciput and the occiput can be felt. How we will, two body masses will be felt at the either side. But how we can come to conclusion which is occiput, which is sinciput? A regular continuous mass, which side it has been felt, that direction we consider as a occiput. The irregular mass which has been felt one particular side, that can be considered as a sinciput. So we can say if sinciput is higher than the occiput, the head is well flexed head, as we are seeing in the picture D. And coming to the picture C, this is a pelvic grip where we see for the whether the fetus has been descended down, whether the movement has been restricted or not. So that is, we call it as a Paulic grip. So how we can say the engagement? Some people will say the head is not mobile, so the head is engaged. That is a wrong information which has been spread all over. Usually we say that head, we have to hold the head in this way, like when the head, 4 fingers of our hand with 1 finger of the thumb, but when we are able to hold the head and the head is not mobile means we can say head is 4/5 engaged. When only 3 fingers can feel the head means 3/5 engaged, 2/5 engaged, 1/5 engaged, and head is no more palpable per abdomen, and per vaginal examination the head is at the 0 station. We can say the head is engaged. That is the thing we will come to the conclusion, the head is engaged. So these are the things which we have discussed, like first manual, that is fundal palpation, second manual, that is the lateral palpation, right as well as the left lateral palpation. Third is the thing where we are seeing about the sinciput and occiput, the flexion of the fetus, and fourth manual to know the attitude of the fetus. So next is the breast examination. The breast should be examined for the size as well as for the symmetry and condition of the nipple, because there are some nipple problems which hinders the breastfeeding in the postnatal period, like retracted nipple, inverted nipple. So these are the things which can be treated during the antenatal period itself, and also sometimes the presence of colostrum also should be expressed during the antenatal period without much difficulty given for the mother. So the rationale is to solve any problems which occurs in the postnatal period during the breastfeeding. So next is the vaginal discharge as well as the vaginal bleeding. So vaginal discharge, like, has the woman about any increase or change of the vaginal discharge? Normally she may have, but it should not go to the extent of mucoid loss. That is especially before 37, which we call it as a cervical plug. Cervical plug is very, very important, which helps in prevention of infection for the mother, especially the ascending infection. And vaginal bleeding, like anytime during pregnancy, it should be immediately reported to the obstetrician, because sometimes implantation bleeding, normally we can consider it may be due to implantation bleeding, or sometimes any rupture of the veins in the cervical area, or because of the loss of the cervical plug. But abnormally due to some antepartum hemorrhage like placenta previa, abruption placenta, or sometimes due to the abortion. These are the probable differential diagnosis. For safer side, it has to be reported to the obstetrician at the earliest. So coming to the, with the finishing with the abdomen, coming to the legs, which we have already said, we have to observe for the edema, and the varicosity of the veins is most commonly observed, or it has been found during the time of pregnancy as the poor venous return. Usually the rationale for having this varicose vein in the lower extremities are the abdomen is so heavy and it compresses the inferior vena cava, so there is poor venous return, which makes the leg to go in for the edematous status. So there is chances for the mother to develop the varicose vein. So accordingly, our nursing intervention should be planned, that long standing should be avoided, putting the legs just like that, instead of we can lift the legs for the mother. So these are the informations, or few nursing interventions can be done. And coming to the third component of the antenatal care, where we discuss about the laboratory investigation. These are the investigation which is mandate and which has to be done for all the mothers. Invariably, all the antenatal mothers should be gone for blood grouping and cross matching. So RH grouping as well as RH typing. Hemoglobin has to be detected for all the mothers, and test for syphilis, test for rubella, urine analysis, and cervical cancer screening test, chlamydial infection test in case of suspected, and the blood glucose level, and stool analysis for O1 parasites, and VDRL again for syphilis, and HBsAg, whether it is negative or positive, it should be. These are the common investigation, if not at least for anemia, blood group, RH group, and RH typing, HIV, syphilis, and hepatitis. These are the mandate and blood sugar. These are the mandate investigation should be done. So this is for the normal mother where her normal pregnancy is expected. Whereas if you think if there is any things related to abnormal antenatal mother, we should also go in for other diagnosis, other diagnostic tests like amniocentesis, choriosynthesis. So all different types of measures of the biochemical and biophysical tests are available, which has to be done. This is for normal mother, normal blood investigation can be done. And coming to the ultrasound. So ultrasound, we have to estimate the gestational age. We have to check for the amniotic fluid volume, position of the placenta, and multi-fetal or singleton pregnancy and the position of the baby. These are the major features which has been grasped, and the nurse should know whether it is appropriate to the gestational age according to our calculation LMP as well as ultrasound, whether it is matching. Whether amniotic fluid volume is less, we call it as oligohydramnios. If it is going to be more, we go for a polyhydramnios. And the position of the placenta, which is very important, because if it is going to be a low-lying placenta or placenta previa so-called, then per vaginal examination is strictly prohibited in that particular time. If at all you found anything in the case of ultrasound, you can write in a red, no PV should be done. So it should be notedly written in the nurse's station. So in future duty also, or a handing over, or other nursing person also doesn't do PV for that. And multiple pregnancy also should be taken into consideration, because when we do one delivery, whether we know the placenta, the umbilical cord, when we cut, we cannot remove the placenta when other fetus, whether it is singleton placenta or double placenta. So for everything we should know whether it is twin pregnancy and also the position of the baby. So fetal kick counts. So it is also important to ask the mother the movement of the baby. 10 movements per 12 hours is a normal thing. When it is excess, we have to consider. When it is nil or less than 10 also, it should be taken into note. Both the way, it shows some signs of danger which can be ruled out by checking the fetal heart rate either through Doppler or through the fetoscope. And coming to the other component of the antenatal care is the antenatal visit. From the time of conception, your proper antenatal visit should be done by the antenatal mother. That is, it is planned like until 28 weeks of gestation, she has to come every 4 weeks once. She has to report to the doctor. Or after 28 weeks, she has to turn to the antenatal clinic. Every 2 weeks once she has to visit the obstetrician. And after 36 weeks, every week she has to come till she goes for the delivery. Especially the pregnancy period is either 40 weeks of gestation or 280 days. Or in 9 months, 7 days. Till like after finishing 36 weeks, exactly 9 months, she has to come every week after that. Sometimes if there is any abnormalities or complication, for example, anemia complicating pregnancy, where she has to go for IFA large, iron and folic acid large, or sometimes IM injection of iron should be done, or blood transfusion. In that case, according to the obstetrician order, she has to make her visit little more higher way. And the last component of this antenatal care is antenatal advices which has to be given to the mother. The first advice is hygiene. So the infection may create a larger problem in the antenatal intranatal also. She should keep her body very clean and neat. She has to take bath daily, and she has to wear the clean clothes, and vaginal douche should be avoided in case of excessive secretion or infection, and as per the guidelines of the obstetrician, she can go for the vaginal douche, otherwise it should be avoided. So regular washing of the genital area also should be done as a part of hygienic practices. And dietary requirement. During pregnancy, we say about 2,500 kilocalories is needed. As per the guideline, 300 kilocalories should be provided extra than the normal. That is just prior to the pregnancy. What is her caloric pattern, which has to be calculated like 30 kilocalories per kg body weight. So in that way, it can be calculated for the sedentary worker. 35 kilocalories per kg body weight can be calculated for moderate worker, and for heavy worker we can calculate as 40 kilocalories per kg body weight. This is for normal women. During the antenatal period, with this calculation we have to add up 300 kilocalories. So the purpose is we have to maintain the extra demand of the growing fetus, and we have to maintain the health of the mother, physical strength and vitality in labor, because in a labor during each contraction her energy is getting expended more and more, and she needs extra energy. For that we have to prepare her throughout the antenatal period. And finally, for the successful lactation, antenatal diet plays a very important role. We have to tell her about the extra intake of the calcium, extra intake of the iron and protein rich foods during the time of the pregnancy. And danger signs, otherwise called as warning signs of the pregnancy, should be said to the mother very clearly. As a nursing person, we have to make a note that every mother knows about the warning signs, and she reports to either nurse or your doctor immediately when she finds the following signs, like vaginal bleeding, including spotting, persistent abdominal pain, severe or persistent vomiting, sudden gush of fluid from the vagina, whether it can be a rupture of the membrane or amniotic fluid is getting gushed out, or absence or decrease of the fetal movement. We have already said 10 movements or 12 movements is okay per hour, one movement, but if it is reduced or if it is increased also, when she has severe headache, edema of hands, face, legs and feet when it is noted, and fever is above 100°F, dizziness, blurred vision, double vision, spots before eyes, painful urination. If any of the signs has been found by the mother during the period of pregnancy, it has to be immediately notified to the concerned healthcare personnel. So that has to be said by the nursing person clearly to the all antenatal mothers. And breast care, we should tell them to wear a firm supportive bra with wide straps to spread weight across the shoulder, and wash and clean under tap water. It is not recommended to massage the breast, as well as we have said that breast massage will help will stimulate the oxytocin hormone to secrete, and we know the oxytocin hormone which is secreted by the posterior pituitary gland indirectly or directly helps in the stimulation of the or contraction of the uterus, which again leads to abortion. So that has to be avoided. Advise the mother to be mentally prepared for breastfeeding. Advise the pregnant woman express colostrum during the last trimester of the pregnancy to prevent any congestion. So these are the things which has to be noted, and the care has to be given in the starting from the second trimester onwards. Dental care, so we should ask the mother to know whether she is using any dentures or any dental problems or dental caries she has. Usually tooth extraction should be avoided during the time of pregnancy, but if the condition is so severe, it can be recommended, but it has to be done with the local anesthesia under the extreme cases, as well as with the suggestion of the obstetrician. And dressing, so avoid, we have tight clothes can be avoided, and cotton clothes can be done, light clothing can be done. So these are the information which has to be said during for the dressing sense. And travel, especially avoiding the travel during the pregnancy is been suggested, and a long travel it has to be avoided, but if it is quite necessary, it has said that in the early part of the first trimester as well as in the last trimester, it can be avoided. In early trimester, if you go for a longer travel, it may induce abortion. In the late pregnancy, if we go for a longer travel, there is a possibility of preterm labor. So this travel information also should be given for the antenatal mother. Same thing with the sexual activity in the first trimester as well as the third trimester, it should be avoided. Coming to the exercise. So exercise should be very simple. There are defined antenatal exercise. Again, it's a very big topic where we have Kegel exercise and also stretching exercise, which has to be taught to the mother, so that teaching the exercise will help the mother to go in for a relaxed muscles, and also gives the strength of the joints, and also helps in the mobility of the joints, which is very much helpful during the time of labor. And we should tell long standing should be avoided in order to predispose to varicose vein, and also leg crossed, the position or sitting in the way of leg crossed should be avoided by the mother as it impedes the circulation. Now let us see what are the importance of or purpose of doing this exercise. To develop a good posture, as we say, the mother always during the time of pregnancy, especially in the later part of the gestation, they have a waddling walk. Just they push the abdomen to the front and they walk. That posture is a very bad way of posture, which many of the mother assumes. Because of that, what happens, the overstretching of the back, especially in the lumbar region, which creates a backache. So we have this exercise helps in to develop a good posture. And when we do some stretching of the exercise, this constipation and insomnia can be reduced, and discomfort, postural backache can be reduced, and we can ensure the good muscle tone and strengthen the pelvic muscles, actually the joints, especially the symphysis pubis joint, as well as the sacroiliac joints, and muscles of perineal muscles. The stretching will help in the first and second stage of labor to have a good tone during the time of labor. And to develop good breathing habits, ensure good oxygen supply to the fetus, circulatory stasis in the lower extremities, which we have already said about the varicose vein and also the edema. So this exercise helps in the possibility of preventing or lessening the white leg or phlebitis. So contraindication. When now we should not go advise the mother to do the exercises. Whenever she has vaginal bleeding, severe anemia, history of preterm labor, extreme over or underweight of the mother, hypertension, heart, lung or thyroid disease. So some of the contraindicator factors when it is there, we should ask the mother not to go for it. So these are the informations which has to be given for the mother. And sleep, very, very important. So otherwise also as a females, we try or enjoy sleeping. But in antenatal period, it is a chance given for all the females to take adequate rest. So 8 to 10 hours of sleep in the night is advisable, and 1 to 2 hours of day nap also encouraged. So we should avoid resting in a supine position. So usually lateral positions can be given for the mother in order to have a good sleep, especially during the term. And also some occupational hazards like this, all the things which has to be avoided. Infections like rubella, toxoplasmosis, syphilis, these are considered as the biggest hazard during the antenatal period. And smoking and alcohol also have a high risk during the time of pregnancy, which create prematurity, fetal death, mental retardation, congenital anomalies. So this has been strictly prohibited not only during the antenatal period. The person who is habitual for that, especially the females who is habituated with that, we have to give a pre-parenthood preparation of not doing that for a minimum 3 to 4 years. Then only we should advise them to go in for pregnancy itself. Drugs are sedative and anticoagulant, antithyroid hormone. If at all she is a regular habituated or using for this for any other systemic disease, this has to be taken into consideration whether it has a direct effect on the congenital anomalies of the fetus. So immunization, tetanus toxoid, and also now we are continuing with the tetanus toxoid as well as diphtheria. We have said 2 doses of injection of immunization should be given, one soon after the confirmation, and after a 1 month interval the second dose can be given. So this is regarding the antenatal immunization. So these are the major factors and major arenas we have just considered. Like we have spoken about the history collection, we have spoken about the physical examination. Under physical examination, we have said about the general examination as well as the obstetrical examination, which include breast examination and also abdominal examination, genital examination. We have also spoken about the laboratory investigations which has to be needed and done, and antenatal visits, antenatal exercise, and antenatal advices. These are the bigger topics has been covered in this antenatal care. And few more things also has to be done, like what all the government supports which has been given in the antenatal care, and there are much more to talk about the evidence-based practice which has become in vogue. So these are the things should be added with the antenatal care. Thank you for this opportunity given.
Thank you very much, madam. It was very exhaustive discussion and it was very nice listening to you. Jaisudha madam and Dr. Amuda ma'am. Ma'am, you can unmute yourself and you can summarize what madam has said. Then we can take up some questions from the audience.
Very good afternoon to one and all. Thank you, Dr. Vijayalakshmi, as Dr. Sivasangita madam said, for an elaborative and extensive lecture on this antenatal care. At the outset, I thank our VC madam and all the doctors, and I wish on behalf of our nursing fraternity a happy Doctor's Day to all of you all, ma'am.
Thank you.
As Dr. Vijayalakshmi has said, that antenatal care, which not only ensures the safer outcome from pregnancy, but also it provides a platform for improving the health status of the mother and baby, as both are being considered as a single unit. So there was a study which has been done by a National Family Health Survey on utilization, equity, and determination of full antenatal care in our country and in Tamil Nadu. So in India, 21% of the pregnant women utilize the full antenatal care, ranging from 2.3 to 65.9% across the state. Overall, 51.6% had 4 or more ANC visit, 30.8% consumed iron and folic acid for at least 100 days, and 91.1% had 1 or more doses of tetanus toxoid. and full ANC utilization was inequitable across the place of their residence. And it was so easy to access it, and maternal education also they had. And in Tamil Nadu, we see that the 45% full ANC coverage was there, with 46.3 in urban, 43.8 in the rural population among the 32 districts. And Tamil Nadu showed that 81.1% of at least 4 AN visits, 71% with the vaccination, and 64% on consumption of this iron and folic acid as per the survey in 2020. And as such, during our advice, as we being the nurse midwives, the future nursing students, we need to educate the mother, advise the mother regarding, as Dr. Vijayalakshmi said, what are the schemes that are available for them during the antenatal period from our government. There are a lot of M.G.R schemes that are available, like starting from Amma Mahaperu Sanjeevi kit. I'm sure like everyone will be knowing about it. The kit which has during first, including the Aish, where it has a first trimester, they give Madalai Palam and Karvaplai Podi, and second trimester they give a tablet Annapedi and Nellikai Legium, and third trimester they give Ulundu Thailam and Kuntrika Thailam, like that. So this is the Mahaperu Sanjeevi kit. And also everyone is aware about the Dr. Muthulakshmi Reddy maternity benefit scheme, which has been given, like previously it was 12,000 has been given to the mother in different installment. Now from 2018, they started giving 16,000 rupees. They increased to 18,000 rupees. And for 5 installment, they are giving it. At the first time, when the mother registers her pregnancy, that we call it as now, that FICME number has been given to every mother. That's we call it as it's a 12-digit RCH ID number. All the pregnant women will have that number. So once it has been confirmed at 12th week of pregnancy, the mother gets an installment of 2,000 rupees. And second installment, they don't give it as a cash, but they give it as the mother's health mix content, which has iron syrup, dates, protein biscuit, avin ghee, albendazole deworming tablet, and towel, which is a worth of 2,000 rupees. And third installment is being given during the time of labor. 4,000 rupees has been given for them. Fourth installment, and the mother completes her third dose of the vaccination for the newborn, 4,000 again. And the final fifth installment, the balance amount has been given when the baby comes with the M.M.R vaccinations. This is the way the scheme has been given benefit for the mothers. Other than that, we have many schemes which has been given by our government, like Pradhan Mantri Suraksha Abhiyan, antenatal diet, Anemia Bharat, Amma Baby Care Kit, Janani Suraksha Yojana, Janani Sishu Surakshana Karyakram, and also they have a maternity picnic and involving the mothers in Valahapur. Bangle ceremony has been done in ICDS and birth companion program. Like this, so many programs have been given by our government for the mother to utilize it. And one specific, this one in Pradhan Mantri Suraksha Matrava Abhiyan. This Abhiyan is not only concentrating on the distributing the tablets, also when the mother is a high risk, the red dot has been given so that where we'll be able to identify the high risk mother and the care can be given and referral can be done for the mother. And there are a lot of studies also been done, like how well the services been utilized by the people, the schemes. And I'm sure Dr. Amuda also has studies related to the schemes which are utilized by the people. Dr. Amuda?
Yes, Madam Dr. Amuda, ma'am, you can add on.
Ma'am, Dr. Amuda has to be unmuted, ma'am. Ma'am, could you please unmute Dr. Amuda? Ma'am, could you please unmute Dr. Amuda? Dr. Vijayalakshmi, can you hear me?
Yeah, I can able to hear you. I think Sivasangita madam has told someone to unmute Amuda, and I think they're just waiting for the technical assistant, I think.
Okay. So till then I can say that Janani Surakshan Yojana, where the cash incentives to pregnant women to attend the antenatal clinics and up for the institutional deliveries is being given, which has really raised to the sharp increase in the institutional delivery from 2005-6.
Ma'am, is it audible?
Yes, ma'am.
Yes, now it is audible, ma'am.
Hello, ma'am. Is that audible?
Yeah, it's audible, ma'am. It is audible, ma'am. We can able to hear you. We are able to hear
Yes,
you.
ma'am. Dr. Amuda, ma'am.
Amuda, it is possible to unmute. You put your thumbs up if you're not able to do.
ஆடியோ வரல அதான் அவங்க எப்படி காட்டுறாங்க
Okay.
ஆடியோ வர மாட்டேங்குது. Even I'm not able to hear you, ma'am.
Can you hear us, ma'am?
I can able to hear Jay Sudha, but I think Sivasangita ma'am couldn't hear us.
What about the students? Are you able to hear us? The faculty who are attending this training?
They can't unmute themselves. So they can't unmute themselves.
Yeah, no, in chat box they can show the thumbs up.
Yeah, if they can show the thumbs ups, I think they can hear us.
Yes,
Please show the thumbs ups in the chat box so that we know that you are hearing.
Yeah. So because of this Janani Suraksha Yojana, the institution deliveries have been increased from 39% to the 79% actually. It's near of doubling that, and the children have been breastfed within 1 hour after delivery for the last 10 years. And because we know that benefit of again the breastfeeding, which really helps to improve the health of the mother as well as the baby. And I request the audience, if you have any queries, questions, please put it in chat box. We'll be able to answer for your questions. Any questions, you can put it in chat box. So till now, there is no questions in chat box. So I'm sure like all of you all have understood clearly about the antenatal care and what are the schemes available, how well we can utilize it.
Good afternoon, ma'am. You are able to hear me, ma'am?
Yes, Dr. Amuda.
Yes, Amuda, we are able to hear you.
Good afternoon to everyone. It is a continuation of what Dr. Jaisudha ma'am explained about various schemes. I'm going to tell about the study which is being conducted for to identify the efficacy and realization of Dr. Muthulakshmi Reddy maternity benefit scheme. So the study was conducted in and around Madurai city. Totally 400 samples were selected, and half of the samples from the private hospital and half of the samples from the government hospitals. And what the findings of the study reveals is that, and the most of the samples, they were aware about the maternity scheme, Dr. Muthulakshmi Reddy maternity scheme, and they were not in a position to decide about whether to receive the benefit or not. And around 54% of the women said it is a very long process. And 82% of the women felt there are too many health checkups in the scheme and which they thought as unnecessary. And nearly 50% of the women said it is very beneficial to the everyone. So this is the efficacy and realization of the Dr. Muthulakshmi Reddy scheme. And one more study, it is conducted to identify the effectiveness of nurse-led birth preparedness package on knowledge, self-efficacy and labor outcome among the primigravida women. So totally 100 women were selected here, and the study was conducted in the government hospital in Tirutani. So here the knowledge in experimental group, in the pretest, all the mother priming women had 70% of them had inadequate knowledge. And in the post-test, and almost 77% they have gained knowledge about the preparedness. And about labor outcome, anxiety. So all the mother, if it is going to be a primary mother, the anxiety, the stress will be more during the, especially at the the last trimester. So here this study helps them to have the low perception of pain and anxiety. This was the main study findings which has been identified in the study. So ma'am, you can continue, ma'am.
Thank you, Dr. Amuda. There is a question from the chat box. Plussy Angel has asked, thyroid drugs can be taken or not during pregnancy?
What is the question, ma'am?
Thyroid drugs can be taken or not during pregnancy by Plussy Angel?
Yeah, of course it should be taken. Of course, it should be taken in order to control the thyroid complicating pregnancy, especially hypo or hyper. Accordingly, the drugs should be taken. But the dosage, as per the consultant with the obstetrician, it should be taken.
Thank you, Dr. Vijayalakshmi. Any other question?
Any more questions here?
Ma'am, any other questions in the chat box, madam?
No questions.
No, ma'am. No, ma'am. No questions.
If there are no other questions, then we can conclude the meeting, ma'am.
Okay, ma'am, sure.
Thank you so much, madam, for accepting this in a very short notice, Dr. Vijayalakshmi, madam. It was very extensive discussion, and we are honored to have you for the webinar. And thank you, Dr. Jayasudha, madam, and Dr. Amuda, madam. You were very prompt, and yesterday we had a short discussion that was very fruitful, except for the few technical glitches. It all went well. Thank you once again. Thank you all the other nursing college principals who have joined and the students, without whom this webinar would not have been a complete one. Thank you once again. We will meet in another series of webinar regard to the nursing topic. Thank you so much, madam.
Thank you so much,
Also,
ma'am.
thank you, ma'am. On behalf of all the nursing colleges, on behalf of all the nursing faculty and the students, we take a bigger privilege and bigger salute for the university on behalf of all the representations from the nursing colleges. We thank you, ma'am, the Vice Chancellor, as well as her team like Sivasangita ma'am and Pushpala ma'am for organizing a webinar. And this is the first time we have come into this webinar series from the university. And we give a wholehearted thanks to you, ma'am, for organizing such a wonderful workshop by gathering all of us in one under umbrella and making everyone same knowledge pool has been created for all the institutions. Thank you, ma'am. Thank you for this biggest effort has been created from the side of university for all nursing students and faculty. Thank you, ma'am.
On the special Doctor's Day.
Yes, ma'am.
Nurses.